this presentation was, I was trying to brainstorm ideas. What would you be interested in hearing about? And I have had a very unique practice and experience. A little bit more about myself. I am a proud Missouri native and a graduate of the University of Missouri School of Medicine, the class of 2000. I spent 15 years on active duty in the U.S. Army, separated from the U.S. Army last summer as a lieutenant colonel. Prior to my separation from the Army, I was a faculty member at USHIS in Bethesda here in the area, and currently am a faculty member at the University of Missouri School of Medicine, which unfortunately the University of Missouri has been in the news quite a bit lately. We are the epicenter of the diversity movement, if you will. I'm sorry that Dr. Nunez is not here because we also have been having growing pains and have hopefully are going to take advantage of this amazing opportunity to improve our diversity, and we're working hard to do that. We have our incoming intern class in OBGYN consists of 3 wonderful young women, an African American, a Muslim, and someone who looks like me, which is more typical of Missouri. But we're excited about the opportunity to bring different perspectives to our population. So my experience in baby-friendly hospitals is that, well, first of all, I'm one of those damned obstetricians who you all have been talking about, sitting there in the back. Jeez. And which is actually very foreign to me because the 2 hospitals where I have worked that have been baby-friendly, both of the baby-friendly movements were initiated by obstetricians. And we were, we have been the driving force in both of those facilities. Fort Belvoir Community Hospital, which is a few miles south of here, became baby-friendly in July of 2014 while I was serving as the department chairman. Women's and Children's Hospital at the University of Missouri-Columbia became baby-friendly last year, right as I was coming on to the faculty. So while I was coming up with this talk today, the following questions occurred to me. I have been very, very busy building my practice as a new faculty member, teaching the residents, and so have not had an opportunity yet to get into or to find my research niche, as our program director likes to say, to encourage scholarly activity with the residents. Just as an aside, we recently had a site visit from the RRC, a scheduled site visit, and one of the 2 areas of concern are that there are very few clinical faculty members who have scholarly activities ongoing with the residents. And so as I was thinking about this talk today, I said, boy, what a great opportunity for research and to get these residents involved in a population that is just ready-made, ripe for the picking, if you will. I welcome your comments and participation throughout the discussion. This is an observational report with some objective information and a whole lot of subjective points of view, and I have nothing to disclose. A special thank you to Angela Love-Zarenka, who is the IBCLC at Fort Belvoir Community Hospital, and also from Fort Belvoir Community Hospital, Dr. Gabrielle Mabey, who was the driving force behind the baby-friendly process there. She is also now a civilian physician out in the Northwest. And then also a thank you to Dr. Courtney Barnes, who is my colleague at the University of Missouri, and who is also the director of the Low Intervention Birth Program at Women's and Children's Hospital. So just to review, as we were just talking about the 10 steps to successful breastfeeding, I won't read them all to you. You all can read in the interest of time. Basically, these are the 10 steps to successful breastfeeding. and kind of the critical ideas behind the baby-friendly process. And then there's that last one, foster the establishment of breastfeeding support groups outside of the hospital. So basically what I did was come up with a list of interesting questions to me and then interviewed Dr. Barnes and Angela. And then the format of this is a comparison between the two with the civilian hospital on top, WCH, Women's and Children's Hospital, and then F Beach, we called it, Fort Belvoir Community Hospital, on the bottom. So how did the process begin? Because, to me, my experience has been basically the military experience on the bottom. We were baby friendly at the military facilities. I was discussing this over lunch. I have never worked at a military facility where we had a nursery. From the time I started my residency in 2000, babies roomed in with moms. And so the concept of a nursery was very foreign to me. So at the military facility, our previous department chair, Dr. Mabey, had been baby-friendly at her previous hospital and was shocked that this brand new hospital, which was considered a state-of-the-art billion-dollar facility based on evidence-based medicine, et cetera, was not considering being baby-friendly. And so she assigned an active-duty clinical nurse specialist to start the paperwork and to evaluate the climate and feasibility of going baby-friendly. Kind of a more casual process at Women's and Children's Hospital, Dr. Barnes realized that babies would disappear for long periods of time into the resuscitation rooms that were attached to the delivery rooms for newborn assessments, et cetera, and then would come back to the moms after prolonged periods of time. And this action interfered with bonding and breastfeeding process. And she felt that this wasn't right. Obviously, it's not right. And so the 10 steps were started as a way to improve that specific deficiency that she saw at that facility. Was the administration supportive? Obviously, the administration is critically supportive at any facility when you're undertaking a project like the Baby Friendly initiative. I wanted to put just an interesting comment here to describe the process, how Dr. Barnes recruited the administration at our civilian hospital. Was that she went to the ethics committee and she made a pitch that becoming baby friendly was the ethical thing to do, that providing formula essentially was unethical to moms, and they agreed with her, and they wrote a letter backing her idea to become baby friendly. And she was able to present that to the administration, who the CEO agreed with it. And so I thought that was very, very unique and very creative idea. Also, it didn't hurt that she obtained a grant for funding, because when the hospital administration can do something for low expense, it's much easier than when they have to shell out a huge amount of money. At Fort Belvoir, it very much helped that the hospital commander at the start of the process was a pediatrician. And he felt that he very much agreed with the process and passed his support to his successive commanders, who were a CRNA and an RN. And so those nurses were incredibly supportive in communicating to new staff members the importance of the program. And like I said, this was a brand new healthcare facility in 2011, and the administration wanted to practice evidence-based medicine, of which Baby Friendly is a great example. So what were the motivators in getting the staff members to go through the training and to support the process? Because you have to have everyone buy into the idea of becoming baby friendly. It's not just a sign you put up. When the site visitors come, you have to live and breathe breastfeeding. And so Dr. Barnes used the pride of being baby friendly. We have a direct competitor, only a single direct competitor in Columbia, Missouri. It is a private hospital, and that hospital is not baby friendly. And so she wanted to be able to say that we were the baby friendly hospital in Columbia, Missouri. And so she used that as a way to motivate the changes in the hospital climate. At Fort Belvoir, we communicated simply that being baby-friendly is the right thing to do. Implementation of an evidence-based practice at this brand new hospital was consistent with the hospital's policies. And so that was an easy sell. What was the biggest hurdle? And this is just so interesting from what I'm hearing today from all of your comments. At Women's and Children's Hospital, the biggest hurdle, the biggest obstacle were the pediatricians, interestingly. Specifically, the fact that they had to delay newborn assessments, so make their jobs a little bit harder and a little bit less convenient. Discontinuation of formula supplementation. They were concerned about this. And the big kicker was bedside rounding. They wanted all the babies to be in one place in the nursery so that they could very quickly go through their rounds and not have to do the assessments in front of the parents, making their jobs much, much easier. In fact, Dr. Barnes threatened to cancel the site visit 2 weeks before it was scheduled because the pediatricians were not participating. And so she went to the hospital CEO and said, "I'm canceling the visit. We're not gonna pass." And the next day, the pediatricians started rounding at the bedside. So that's what it took. That's all it took. The biggest hurdle at the military facility was not the pediatricians. The pediatricians were not an issue at all. They were very much involved with the process from the very start. And there's no NICU at that particular hospital, only a special care nursery that was run by a neonatal nurse practitioner. The special care nursery was integral to the skin-to-skin process in the operating room and couldn't have been more supportive. But the high rate of turnover in active duty personnel, those of you who are familiar with the military know that we move to a new place every 2 to 3 years. And so every 2 to 3 years, right in the middle of this baby-friendly process, we would get a new crew of nurses or providers, and we would get the same types of obstructive comments over and over again. So we would have to start at the beginning and explain why we were becoming baby friendly and basically reinvent the wheel. Whose support was critical? I've kind of gone through this in the previous slides, but I do want to highlight one important fact, and that is that the committee at the military facility was a true multidisciplinary team. The chairs of OB, PEDS, anesthesia, and an administration or command representative composed the initial breastfeeding committee, and also included members of the head nurses, radiology department, the lab, and the nutrition department, because that facility was also very much a patient family-centered care facility. We also had a patient representative on the baby-friendly committee, which I feel is important as well. That's compared to the civilian facility, this particular civilian facility, which was more OB driven than multidisciplinary. The training was very, very similar, except for the fact that every hospital employee during the initial training at Fort Belvoir took part in a 15-minute online training. So, and it was a hospital that involved, had all specialties in it. It wasn't just a women's and children's facility. So every single physician, every single janitor, every single logistics staff, everyone did a 15-minute online presentation. And then that presentation was incorporated into the new employee orientation. The women's and children's, on the other hand, is only a women's and children's facility, although they do incorporate the short baby-friendly introduction in their new employee orientation at the present time. Were there hidden costs? The overtime required for the nursing training was incredibly expensive for the civilian hospital. Now, when you compare that to the military hospital, the nurses weren't allowed to work overtime. They weren't allowed to be paid for overtime because of the fiscal constraints of the working in a military environment. They were given a period of 6 months, and they had to get it done. It wasn't an option for them. How long did it take? At the civilian facility, it took 2.5 years. At Fort Belvoir, it took 4.5 years. What is the current breastfeeding rate? At women's and children's, at the present time, our most recent data shows that the exclusive breastfeeding rate at the time of discharge is 80%. At Fort Belvoir, it's greater than 87%. Sometimes higher, sometimes lower over the last 6 months. Prior to becoming baby-friendly, the breastfeeding rate at Women's and Children's Hospital was only 50%, and half of those women supplemented with formula. So this has had a great impact on our breastfeeding rate. A quick note about the Fort Belvoir staff is that the lactation consultant, and there's only one at Fort Belvoir, the lactation consultant is a contract employee, meaning that she has a certain number of hours that she can work per year. And when those hours are up, she has to stop working. She can't work overtime either. And so at the end of the fiscal year, we had noticed a concerning trend that when she started running out of hours, our breastfeeding rates went down. And when I spoke to her a couple of weeks ago, she was really excited to tell me that with education to the OB clinic staff, just speaking a little bit as to what we discussed before, getting the obstetricians, getting the medics or the MAs, medical assistants, involved with this training has significantly improved the dips that we noticed prior to becoming baby-friendly. So I thought that was a very interesting observation. Is baby-friendly a marketing tool? Well, initially at Women's and Children's Hospital, the marketing department didn't think it would be that important. And we think they're wrong because we actually all wear T-shirts now that say Columbia's only baby-friendly hospital on the back of it. And you'll see in the next slide that our delivery rate has started to increase over the last couple of months. And I'm going to be following that trend over the next year to see if this is just a blip or if this is actually real. At the military facility, Fort Belvoir felt that it could be a marketing tool But the population is a little bit different. The military beneficiaries can seek civilian care, but that comes at a price. They have to pay a copay if they go outside of the military system. So most choose to deliver at military facilities. In this area, Fort Belvoir directly competes with Walter Reed, which is not baby friendly. I hate saying that they're not baby friendly. That seems very not nice to me. But Fort Belvoir directly competes with Walter Reed, and the patients have a choice. The Fort Belvoir Hospital, which is more patient-friendly. It's truly a community hospital, and the patients who want that type of environment for delivery come to Fort Belvoir. We had noticed that, and I think my next slide is about delivery rate. We had noticed that Fort Belvoir's delivery numbers have increased slightly, ranging about 130 to 150. When I was working there, our delivery rate was about 120 to 125. At the same time that Fort Belvoir's numbers have increased, Walter Reed's numbers have decreased. And so we're picking up more of the numbers that traditionally would have gone to Walter Reed. And it could be due to a combination of things. It could be that most of the deliveries at Fort Belvoir are performed by nurse midwives. It could be the patient and family-centered care. There could be a lot of things. It's a brand new hospital. It's pretty when you compare it to Walter Reed. So that kind of muddies the water. At Women's and Children's, the delivery rate last month, we delivered 194 babies, which is the highest, biggest month we've ever had at the hospital. When I first got there about a year ago, we were delivering about 170, 175 per month. And out of the last 6 months, we have delivered more babies than our direct competition, which, again, I'm going to be following those numbers, but I have to believe that it is due to us advertising, being baby friendly, as well as advertising our new low intervention birth program. Neither of these facilities are planning future research projects, which just dumbfounds me. And that's, Dr. Graham this morning said to remember three things. I only have 2 things, and one of them is that baby-friendly hospitals are rich environments for research opportunities, particularly for residents. And as soon as I get back to Mizzou and meet with our new interns, we're going to have at least one of them picking up on some of these ideas. A word about breast pumps and breastfeeding rooms. Both hospitals provide inpatient hospital-grade pumps. WIC actually available for the military patients and for the patients at Women's and Children's. And most of the Missouri insurance companies provide free pumps delivered to their front doors, which I just heard a couple of days ago that the lower income patients that we have, our Medicaid patients who are actually less likely to breastfeed, are getting these free breast pumps and then selling them on eBay, which is a little bit disappointing to me. And we need to figure out how to stop that from happening. But unfortunately, we have challenges with our population as well. About half of our patients are private insurance, university-based patients, and then half of them are very rural patients, Medicaid, very low income. There's a lot of meth use in rural Missouri, and so always looking for an opportunity for for $1, unfortunately. In the hospital and the clinic, there are 6 designated breastfeeding rooms, which are very, very nice and quiet, very accessible. The signage is very good. In the military facility, TRICARE did not previously cover breast pumps. So this is new that they are now covering the cost of breast pumps to patients. They used to cover them for patients under certain ranks. So the lower ranked individuals would get breast pumps, but now everyone does. And then all patients are specifically taught hand expression. There are only 2 breastfeeding rooms in the hospital and clinic, but hospital policy is very clear that it allows women to breastfeed any place where moms and babies are welcome, which is essentially the whole hospital. Both facilities only have 1 lactation consultant with rounding responsibilities. Although at Women's and Children's, they have an additional 8 to 9 lactation consultants who are on the nursing staff. Both facilities provide a free outpatient lactation clinic, which I think is going to satisfy number 10 on the 10 steps. We're also developing a breast milk cafe, which we saw in the south of the border lecture. And at Fort Belvoir, they're in the process of hiring at least 2 more IBCLCs, which is great news. I asked the individuals who were the driving force behind Baby Friendly what their biggest accomplishment was. And Dr. Barnes said that she was proud of the teamwork that she achieved to keep moms and babies together, and how well everyone worked together finally at the end, because it was much easier for everyone to have all the babies in the nursery and the mothers sleeping all night long. And Angela at Fort Belvoir said that we actually did it. That was my biggest accomplishment on the first assessment. When I asked her what motivated her to become baby friendly, she said to me, "I didn't want to do it. I told Dr. Maybe that it was going to be way too hard, that we shouldn't do it." But so she was dragged kicking and screaming into the process. So some similarities, which I've pointed out and just highlighting them here. Obviously, hospital administration is critically important when you're going through this type of undertaking. Ethical considerations, like I said, very creative utilization of justification there, and then also using evidence-based medicine. Unfortunately, both facilities are not utilizing this rich data environment, and especially in the military, where you have a closed system, with an electronic health record that tracks people from, the battlefield in Afghanistan to Guam to, Puerto Rico. I mean, just all over the world. So I'm just kerflummoxed by the fact that no one is using this data. Both facilities have limited resources, one being a military facility, and then the other being a state-run or state-funded facility. That is understandable. But both facilities have plans to expand services due to patient demand. This has really taken off at both hospitals. Some differences. Becoming baby-friendly took longer at the military facility. I can only surmise that it was mostly due to the staff turnover and having to train people over and over again, not the same people over and over again, but realizing that all of a sudden you've only trained 75% of the staff, and last week you were at 85%, and now you have all these new staff members to train. And that was a big hurdle that Fort Belvoir had to overcome. The amount of pediatric support was also very different, as I've mentioned multiple times. At the military facility, for those of you who are familiar with the Team Steps program, that program is mandatory at all military hospitals now. And so there is an extra feeling of teamwork at military facilities. Additionally, you can basically, how to say it nicely? Well, involvement in the military in this type of program for the active duty personnel is required. When your commander tells you to do something, you do it. So that might have been one of the reasons that pediatrics was so willing to play with the obstetricians. I honestly think that if pediatrics had been involved in the process from the beginning at Women's and Children's Hospital, that they wouldn't have had the issues that they did have. And then marketing tool. Baby Friendly, I think, has made a big difference in the delivery volume at the civilian hospital, whereas it hasn't made that much of a difference at the military facility. And I think where the differences will show up are more in the pediatric and maternal outcomes, which need to be looked at. So, future research opportunities, there we have it. I think I've talked quite a bit, and I know we're rushed on time. So, any questions?
What research would you like to see them do?
I think that there's some great opportunities. You know, I just did a quick search of breastfeeding and depression, the relationship, not just if there's a decreased rate of postpartum depression, which there have been some small studies that have shown that, but is there a higher rate of postpartum depression when mom wants to breastfeed but can't? There's so many different permutations. I think that's an excellent opportunity. I think there is an opportunity for looking at postpartum recovery from anemia, in breastfeeding women. I'm not sure why the ideas didn't come through on that slide, but I had 3 or 4 things listed up there. But I think that those two, just starting there, and once you start coming up with 2 ideas, those ideas just mushroom into more.
Cindy Howard. I just wanted to make a comment. The motivation for these 2 facilities becoming baby-friendly coming from OB is wonderful. But your story of why this happened speaks to something that I've thought was important for a long time. The trainees and young faculty work in facilities that are baby-friendly. And then they know what a wonderful environment that is. They go to the next place and they say, why are we not doing this the way we ought to be? So I think that the most important facilities to become baby-friendly in any country are where your trainees are.
Yeah, absolutely.
It's absolutely vital. And I'm interested in this increase in market share because I've not seen that at 2 baby-friendly facilities. I've not, been involved in the process in 2 facilities. And
you haven't seen it?
No.
Interesting.
No.
So I definitely want to look at that.
But, breastfeeding's sort of, there's a tipping point with all of this in terms of community knowledge, women's demands for services and things. So it could be that we're finally going to get, some play out of this. But I'm very excited to hear that this came from OB and that you guys had worked in facilities where you knew this should be the norm.
Right. Just a quick comment. One of the trends that we had noticed in the military, especially here in the DC area, is that we were attracting patients who wanted midwives and wanted unmedicated births, wanted low intervention. And we have recognized, and I still speak of myself in the we as the military, but I haven't gotten out of that mindset yet. Even our consultant to the Surgeon General, who was formerly he's the former consultant, is a maternal fetal medicine doc, and he and I spoke at length about this. Is, we have to, as obstetricians, we have to embrace this, because we will lose patients. We're losing patients. If we don't bring midwives into our practice, if we don't support the low intervention practices, because that's where obstetrics is going. And right. It's a natural process. And there are always going to be patients, who need to have a C-section, or, who are high risk, who are preeclamptic at 27 weeks, whatever. But for the vast majority of women, they can be cared for and delivered by midwives. And I should be a consultant, and patients want this now, especially military patients. So. Right. Exactly. Right. Right. And that's, I was in Europe for 6 years in the military, Germany and Italy, was fortunate enough to practice with midwives at both of those facilities. And at Fort Belvoir, we were honored. It was such a great opportunity to open this facility where we were able to design labor and delivery however we wanted. And so we designed it with the midwives take care of every laboring patient. The physician is there for consultation. And that's just the way it was. If that's not what you want as a patient, then you can go to Walter Reed, Yes.
I just wanted to comment how you were talking about the military hospital being a closed system and how much opportunity there is there in terms of surveillance and research. In the United States, we don't have a good way of, keeping track of data on breastfeeding over time. It's a lot of surveys and things like that. So I just wanted to comment that that's a great opportunity for doing longitudinal studies.
It is, and that's why the system was developed in the first place, was for an eye to research in the future.
Would you give us your name and what you're doing?
Oh, sure. My name is Sadie White, and I'm here from the nonprofit Health Connect.
I'm Casey from Rochester. You're all sick of me by now. It's a follow-up, actually. It's perfect because one of the things that's really upsetting about why we're not doing the research is because the data is not organized. And it's frustrating because the data is becoming organized in lots of other fields. Like when I open up my e-record or Epic, whatever you want to call it, I can find out how many charts I have open. If I were a family medicine provider, I could see my hemoglobin A1Cs, my blood pressure. And I've worked with several different Epic sort of e-record people and institutions to try to figure out where breastfeeding sits in the EMR, and it's not a problem, so it doesn't fit there, and it's not necessarily a vital sign. Some people build it under a tab, some people build it under a flow sheet, and it's really complicated. And so one of the larger asks, and maybe this goes back to Tim's point from earlier, is until this becomes a measure, like a HEDIS measure or something like that, that people have to start paying attention to and build into their EMR so that they can put out to these national organizations, it's going to be so much harder to do this research. It should be so easy to pull this data. You should be able to just click a button and get it on a flow sheet right there every month.
No, I completely agree. And for those of you who, right. It's a ORIX measure, isn't it? The Joint Commission. Yeah.
It's a
Exclusive
joint commission.
breastfeeding at discharge is the
Which is, it's one measure. It's just not longitudinal, yeah.
right.
So if there were some way of creating national data sets on how people could get this information and share it with each other.
Well, there's the National Immunization Survey.
Right.
It has very sketchy data, but at least you can get measures of duration of breastfeeding now that they've adopted.
If anyone is interested in contact information for someone who works at a military facility who wants to potentially work together on a research project and following longitudinal data, since they have that available to them, I'd be happy to provide some contact information. So.